Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Dr. Keith Lillemoe is the Chief of the Department of Surgery at Massachusetts General Hospital in Boston and the Editor-in-Chief of Annals of Surgery. We spoke with him about equity in surgery, bile duct injuries, and the challenges of being in charge of the Annals of Surgery, as well as leadership in general. Check out the show notes below for links to all the papers that we discuss, including the Consensus Conference guidelines on bile duct injuries.
I think we all, probably North America and the world, know exactly who you are, of course, but I was wondering for any listeners who may not know you closely, if you could sort of give us a sense of your training and career path and tell us how you ended up where you are now.
Okay. Well, first of all, thanks for the opportunity to be part of this. I'm excited and look forward to you having some challenging questions and some good discussion. So I guess I'll start with the very beginning. I'm a farm kid from South Dakota. I actually went to college at the University of South Dakota and did my first 2 years of medical school there. I then transferred to Johns Hopkins in Baltimore, which obviously was quite a culture shock for my last 2 years of medical school, but we seemed to like it, and so I stayed there for the next 29 years. I did my general surgery training at Hopkins. I joined the faculty there and stayed there until 2003. I finished my training in the days before there weren't a lot of fellowships, so I consider myself a general surgeon. But over the course of time, my practices sort of migrated to mainly pancreas and biliary, not much hepatic surgery. I don't do any colorectal anymore, and other than bread and butter general surgery, hernias and lap choles, I guess pancreas has become my niche just because of just the way referral patterns developed both at Hopkins and then later at Indiana and now here in Boston. I left Hopkins in 2003. I was at the Indiana University from 2003 till 2011. That's where I obviously had the pleasure of working with you, Chad, as our fellow a few years before I left. And then in 2011, moved here to Boston and to the Mass General Hospital. And everything was going great until about 2.5-3 months ago. And now we're facing what for most of us is the biggest challenge of any kind we've ever seen: medical, society, economic. It's an interesting time. It's scary, but I'm confident our technologies will catch up with this disease, and the day will come soon where we'll be back to some normalcy, but it may be a new normal.
You're such an international leader, and I would even say icon for sure. Like you said, with regard to pancreas surgery, with regard to bile duct injuries, and probably now COVID as well. But maybe avoiding those topics, at least for the start here. You've also clearly achieved the pinnacle of surgical leadership, whether that's at Indiana and then subsequently the Harvard system as the chairman of surgery, or of course the president of the American Surgical. Just so many examples. When did you know you wanted to pursue that aspect of your profession?
So, my first role model in surgery was a private practice, solo practice general surgeon in this little town in South Dakota. And, I came to Johns Hopkins, having never been around surgical residents or been in an academic medical center. And so it was it was what I grew up with, was at Hopkins. And I have to say, you you emulate those who are your role models, and I was very fortunate at Hopkins to have lots of great role models, but probably the number one person that was John Cameron. And John instilled a lot of things in us, a lot of tough love, but one thing he instilled upon us is that we should be leaders, and leaders, not just national leaders or department chairs or anything like that, but no matter where you are, you should be a leader, whether you're the leader in your community surgical group, whether you're a leader in your local or state chapter of the American College of Surgeons, or whether it be a leader of national organizations or major academic departments, you should strive to be leaders. And the track record at Hopkins of leadership, going back to the products of Halstead and then Blaylock, and then more recently the products of the Cameron residency, has shown that something about the institution instills the desire and maybe even the expectation that you will become a leader of a department of surgery. And so when the opportunity came to go to Indiana and to be a leader, I certainly took it and very much enjoyed the opportunity. And certainly there was no way I would say that the job was done, but the move to Boston, the MGH, added another layer of complexity to the leadership and another set of challenges. And so that's sort of the pathway of leadership that I've had. The national leadership opportunities, a lot of these come again from people helping mentor you and direct you and opening doors, a crack for you here or there, getting you on a committee or getting you a entry-level appointment as one of the worker bees in the organization. I was secretary of the SSAT. I was secretary of the Society of University Surgeons, both which ultimately culminated with being a president. And same with the American. I was the recorder, which gave me the opportunity to, get to know the organization, serve the organization, and to develop the connections in the organization that led to the opportunity to be president. I've said this many times, and it's not original, but when you see a turtle on top of a flagpole, you knew the turtle had a lot of help getting up there. And I'm the turtle, and I have had a lot of help along my career in every facet, and just consider myself very fortunate.
It's interesting that you highlight and you bring up essentially mentor pedigree, because I was sort of thinking of exactly that earlier today. As you know, being a football fan like you are, Don Shula died, and I was looking at his coaching tree, and then thinking in the context of Belichick and Andy Reid and these guys, and then of Dr. Cameron and you, and it's amazing where quote unquote Dr. Cameron's offspring, including you, have ended up, and so on. Those generations of leaders are going to be around for a long time, and the impact's going to be felt for probably forever. One of the really interesting things that I always thought about you in particular was the groups of people that you've had around you. And sure enough, it sounds like you walked into some of it at Hopkins and were certainly a participant in developing it. But how did you develop such an amazing group in Indiana and then at MGH? These are some of the absolute best of the best folks, and they're amazing clinicians and also amazing humans.
Well, at Indiana, I followed a real giant in American surgery, in Jay Grosfeld, and he had set the the bar of quality very high at Indiana University, and it was a small department, and we took the opportunity to grow it, and with the opportunity to grow, I was able to recruit some good people, again, many with Hopkins pedigrees that made it like bringing family and friends in to help me grow it, and so that was key there. And then I think coming to the MGH again, the place was a tremendous program. It was tremendous faculty, tremendous residents, but it gave me a chance to institute a perhaps more of a cultural change than any major transition in any other aspect. And it was good timing because, if you look at the culture of where everything was in America and in surgery and things like the Me Too movement and things like that have come along in the last 5 years, I think your traditional surgical departments would be really struggling now if they hadn't made cultural changes. And I think that changing the culture has allowed us to recruit, great residents. Many have gone on to become great faculty members with us or elsewhere, and it's also allowed us to recruit people from outside the MGH to come in and be exceptional contributors. It's been fun to recruit a couple of division chiefs over the last few years that were from outside of the MGH, and that was good. A little introducing some new blood is always a good thing. And again, for junior faculty too, we've got a pipeline of some great junior faculty that have come from other institutions to again help us round out our culture.
That's a perfect segue to your presidential address. When you were the boss of the American Surgical Association, and it talked about a number of things, of course, but the two dominant issues that you demanded attention about and really talked eloquently about were equity and equality in surgery. I was just curious what led you down that path, and then if you can comment on what was clearly had become a passion for you and some of those improvements moving forward, including the document that you guys published about some of the inequities in research itself.
So I guess I would say being the father of a female surgeon changes your perspective on it a little bit. So I had that going for me. You've met my daughter, Chad, and you know that she's headed the lines of surgical oncology, and so again, maybe the apple doesn't fall far from the tree, but I had grown up in a program where there was very few women residents, even less attendings, and had seen as the shift in medical students becoming at least 50%, if not greater percentage women, that surgery was going to shoot themselves badly in the foot if we didn't find a way to make our life more attractive to people of all genders, all persuasions, all ethnic backgrounds, and I just thought it was time that someone spoke up about some of the things that had been viewed as inequalities. And the American Surgical, as great an organization it was very slow to make the transition. When I gave my presidential address, there'd only been one woman president. The percentage of women in the organization was in single digits. You could say, well, the pipeline isn't there. People have to progress to get to be members of an organization like that. But, we had to overcome, those unconscious biases that do exist. And unless somebody would bring these to our attention, whether they be on search committees, whether they be on promotion committees, whether they be on membership committees for prestigious organizations, somebody just had to say, look, we have to make sure that we have a open and level playing field across all factors. And although I gave my presidential address on really gender inequalities, I did open the door for the next year when Ron Mayer was president to extend this beyond just gender into all areas of inequalities, and led to the document that you referred to that I think is a very nice tool for anyone who's looking to establish programs in their own department.
Yeah, I think you're right. I think that document's going to live on for a long time, and it's really changed perception and process and structure in lots of places. One of the things that is clear to everyone in the world is the impact you've had on our field through peer-reviewed publication. And again, having spent time with you in Indiana, I was always impressed by the productivity of that group, in addition to Hopkins and of course Harvard. But I was curious, how do you ensure that productivity? Is it the chicken or the egg? Is it the people you're hiring, or is it the structure? I mean, I fondly remember as a fellow getting to sit in on the monthly research HPB meetings, which were fantastic. But which and how, I guess, is the question.
Likes attract, and you want to go to a place where you have a high level of productivity, and the driving point behind the good clinical care is asking the questions that need to be asked to make the clinical care better. And if you come from an environment where you're stimulated to ask questions and translate the answers of those questions into research and academic productivity, I think you can find that adds another layer of success to our careers, and it does help in the areas of promotion and recognition. but again, it really is all about advancing the knowledge that help us take care of patients better. And I have been very fortunate to be surrounded by people at all three of my institutions that sort of shared that love of academic productivity, and again, I've been along for the ride a little bit here at the MGH. I'm not doing too much original research myself, but we do have a very productive group here, and it's fun to have that stimulus to keep your eye on the ball.
One of the things you're clearly an expert on and have done some really fantastic work, not only on researching it, but also talking about it, is bile duct injuries. And I think as a resident, listening to and reading stuff that you've put out has been incredibly useful in understanding this problem. I was hoping you could give a short overview of some of the pitfalls in actually what goes into causing a bile duct injury, and then talk us through how you would approach that if that happened.
So first of all, it has happened to me. I've cut a bile duct and recognized it and had to make those decisions. I'm going to do a little self-promotion here. In the July issue of Annals of Surgery, the Safe Cholecystectomy group, which came out of SAGES and then expanded into all the other major surgical organizations, is finally publishing the proceedings of the excellent all-day symposium and consensus conference that was held at the American College of Surgeons in October of 2018, and that goes through all the major questions and decision-making points related to prevention of bile duct injuries, recognition of bile duct injuries, and management of bile duct injuries. So I don't know when this will actually hit the airways or the podcast will become public, but if the people will wait until the July issue of Annals comes out, I think everyone will be have a lot more knowledge instilled with them than what I will talk off the top of my head on it. But I'm very pleased that group has worked so hard on it, and I have to give credit to Mike Brunt, past president of SAGES, for really making this a passion of his presidential address, and then keeping it going and enlisting all the other organizations. So that being said, obviously like anything, the best way to treat a bile duct injury is to avoid it. And I think we've learned a lot through the years about how to do the operation more safely. New techniques such as the critical view of safety, which isn't so new anymore. It's 20 years old now, but it is a technique that I think if done properly, can and do just about everything necessary to ensure avoidance of an injury. And it's really most valuable in those easy cholecystectomies because if you get in there and the cholecystectomy is too easy, you kind of let your guard down. I think everybody gets very concerned on a tough cholecystectomy and really says, oh, we really have to be careful. But I would guess that if you really could analyze all the lap chole injuries that are done in America, more of them were probably done on easy, straightforward lap choles than were on the tough acute cholecystitis cases. So the nice thing about the critical view of safety is that it should be achievable in just about every patient, and if you just take that little extra time, and we're really talking about a matter of minutes, and check and double check to be comfortable with the anatomy and know that the structures that you're cutting and dividing are going to the gallbladder and the gallbladder only, you I think are about the safest that you can be. Other things that have evolved over time is recognition that not every gallbladder that you tackle, particularly for those who do the acute care surgery of the world, and are doing the gallbladders that come in, and they're really getting tough now during COVID. People are sitting home with bad cholecystitis for 3 or 4 days because they're afraid to go to the hospital and come in on day 5 or 6 and the gallbladder is all matted in. And the concept of partial cholecystectomy hardly existed 10 years ago. Most people would do whatever it took to get the gallbladder out, and now I think recognizing that doing a partial cholecystectomy or even a cholecystostomy tube, if the case is just too tough, is a way to avoid injury. As we've become aware, actually the open cholecystectomy, particularly in those cases that are tough to do laparoscopically, has perhaps become the most dangerous operation in America now, because most everyone who trains has grown up doing lap choles and very few open choles. And so, again, unless you're in a program where you really have a busy emergency room with a lot of acute cholecystitis coming in, you're not necessarily cutting your teeth on the tough open chole. And so I do think recognition that injuries can take place and taking every step to avoid them is the most important thing. Once you've recognized you've had an injury, and again, the data would show that the majority of bile duct injuries are not recognized at the time of the actual laparoscopic cholecystectomy. They're recognized in the post-operative period. But if you do recognize it at the time of surgery, the best time to repair it is, if your situation allows, is that at that time. The first thing that you do is you look around, where are you and who might be there to help you. And if you're in a situation where you're in an ambulatory surgical center and the patient was going to go home and you don't have all the big retractors and the instrumentation to do a reconstruction, you shouldn't be trying it. Whereas if you're in an academic medical center or even a community hospital and there's a more experienced surgeon, particularly someone who's had surgical oncology or HBB or transplant training, always get help. You can't let your ego stand in the way of doing what's best for the patient. And if doing what's best for the patient involves asking a senior surgeon to come in and help you do the case or help you recognize the nature of the injury or just offer advice, I think is the first thing that can be done. Then finally, if when you do go about the repair, is follow good concepts of surgical technique. Debris damaged tissues, avoid tension on your anastomosis, which in most cases for bile duct injuries involves not trying to bring the two ends of the bile duct back together as a end-to-end anastomosis, but to bring a Roux-en-Y limb up there, which is a tension-free anastomosis with healthy tissue, which I think is important. Follow good surgical principles, external drainage in case there's a leak, and again, my personal bias, again, going back to the days of Hopkins training, was, if there's a way to put a stent across the anastomosis for that immediate postoperative period to control the bile leak, that's not a bad thing to do. I don't think a stent is required, but it's certainly a safety net. It's sort of the belt and suspenders that one can use to make sure that if you do have a leak, that it's a controlled leak and doesn't lead to worsening consequences after your repair. Again, recognition, get help, make the proper decision as to, is this the time and place, and am I the surgeon to fix it? And if all those things check the box that you can do the repair, is, again, follow good surgical principles. Since most injuries are recognized in the postoperative period, the decision-making of the surgeon when they identify, whether it's in the emergency room or after the patient's been readmitted, that they have a bile duct injury, again, to look around and say, is this the institution where we can provide the best of multidisciplinary care? Do I have the interventional radiology backup? Do I have the endoscopy backup? Do I have my own surgical skills to allow me to do that? And if not, maybe the best assessment is to transfer the patient to a center where they do have all of the teams to be able to take care of the patient and provide the kind of care that ensures good results. There's very few cancers that we treat that have a 90% survival, but bile duct injury should have about a 90% success rate, and if it's done in the proper institutions, that those numbers have been classically reproduced many times, at least in 5-year follow-up. And so I think, again, thinking to where the patient would be best managed is oftentimes more important than just trying to take care of your own complications.
Dr. Lillemoe, someone who has obviously a bird's eye view of how this topic has developed over the last few decades, I'm curious, and this might be a spoiler for your Annals of Surgery July edition, but I'm curious as to where you think the management or prevention of these injuries is going to go. Like, as you said, the critical view of safety has been there for 20 years. Do you think that the issue is going to be just ensuring that everyone knows it, or do you think there's still things that are on the horizon to make us better at avoiding this never injury?
That there is extensive discussion about alternative techniques, intraoperative ultrasound. There's dye tests that you can do, particularly with the robot, that helps you better identify structures and the like. So, I do believe technology will catch up with us. The one that I like to tell the story about, and again, a little bit of self-promotion to a group that we have at the MJH is really machine learning. And, Chad probably drives a Tesla, but I don't. But
not yet.
I do have a car that when I cross the lane, my steering wheel shakes a little bit. And if we could train our laparoscopic equipment, the camera, to process the performance of a procedure, and through having studied hundreds and thousands of lap choles, that if I could get a little like dog collar shock on my hand through my Maryland dissector when I'm about ready to encircle the common bile duct, thinking it was the cystic duct, that would probably deter me from wanting to proceed. So I do think technology will come along, and I would like to think that it would be available without the expenses of robots, and just be applicable through machine learning techniques that get applied into the camera system that we have right now. And I know companies, I do not have any a personal conflict of interest with this, but companies like Olympus are working on these techniques to try to make for safer surgery.
If we switch gears here just a little bit, Dr. Lillemoe, you've been a mentor to dozens and dozens and probably hundreds of us now, and you continue to be so. at a very close level. I was curious, sort of at a 30,000-foot view, what does the term mentor mean to you? How do you approach it, and what advice would you have for junior staff or all the way through in terms of being a great mentor?
So I think mentor is someone who really cares as much about advancing their mentee's career as they do their own. And they're willing to put in the time and effort to listen and to talk and to guide and to provide feedback at every stage of your career. And I still believe I have mentors now that help me. And so I think you never are too senior to not have mentors. And again, as I alluded to, being a mentor is a way of paying back to the people who mentored me all the way through my career and provided opportunities for me. So, I always consider myself very fortunate if someone seeks me out to be a mentor, and having been a program director and a chair now for, chair for 17 years and program director for 10 years on top of that, I do get placed in the opportunity where I do get a chance to talk to, medical students, residents, trainees, and faculty and fellows, mentoring from everything about where they should match in the NIRMP to where they should do their fellowships to their first jobs and the like. But there's also mentoring in terms of how you conduct yourself professionally and the example that you set. I think we all are exposed to a lot of people who could be mentors, and I think as you as a young person are looking for, or anyone who's looking for a mentor, they should try to look at the characteristics and the qualities of the mentor and say, that's really where I'd like to be in X number of years. And my first mentors were first and second year residents at Hopkins when I was a medical student. I just wanted to be like them. And then when I became a junior resident, I wanted to be like my chief residents. And when I became a faculty member, that's when I started recognizing that I had to have mentors that will help take me to the next level. And again, fortunately, there were several around during that period of time. And so the good thing about mentoring is, even though the focus is really on the mentee, that again, I hate to come up with all these corny statements, but light shines brighter off of when it's reflected off someone else. And so if you have success as a mentor and your mentees rise to levels of success, people will figure that out, and you'll get some credit for it. So it is mutually beneficial, but really the better job you do in helping the people you're trying to be a mentor for in achieving their goals, the better you will be.
One of the other many jobs that you do off of your desk is, of course, the editor-in-chief of Annals and Surgery, and certainly this audience knows and feels that Annals is clearly the preeminent surgical journal in the world. I was curious, just 3 rapid-fire questions about your that role in Annals. How do you view that job? Would be the first question. The second question, it's a bit biased because I've spent enough close quarter time with you that I have seen how you actually fit it into your day. But for our listeners, maybe describe how you do that. And the third thing, both selfishly from the professional side of things as well as curiosity, how do you deal with an upset author who maybe didn't like 1 or 2 or 3 or sometimes 4 of the reviews and sends you that terse email?
So let's go from the last question first, because I dealt with that today. Paper that was rejected generated a polite email pointing out why they disagreed with the decision. And so the first thing I do is I listen to them, and I look at what the reviews said and what their response is. And then I, in the case today, it was a paper that we had 3 reviews on. And one review was high accept, one review was flat out reject, and one was sort of intermediate. So it wasn't as if this was a slam dunk either direction. And I said, but I sent an email in response to the email that I'd received saying, I'll rescind your decision, and I will send it out to someone who has not seen it before. Let them take a look at it and give me a new, fresh set of eyes. And fortunately, one of the good things about COVID, there are a lot of us who've had a little bit more time on our hands, and I'll get into that in a minute to your second question. But I sent it to a very well-respected surgeon in that area, and he said, I'll look at it now. And within 2 hours, I had a response from the 4th reviewer that the paper should be rejected. And I had established with the with the authors, I said, I'm going to send it to one person, and if that person says accept, we'll accept, and if he says reject, we'll reject. And in this case, the decision went along the lines of our original decision, and at least I gave a person a chance. Now, sometimes I'll look at it, and there was 2 or 3 very solid rejects, and I just have to say, there's not much you're going to do that's going to overcome this decision, and don't go to quite as much work as we did today. But still, I think you should at least listen to their arguments and go back and look rather than just flat out say the decision is a decision.
Just out of curiosity, given the massive number of submissions you guys at Annals get, how common is that scenario where you have an upset author sending that email back to you?
Oh, I would say it's probably a weekly occurrence.
Is that right? Wow.
So we're on pace right now for well over 3,000 submissions, and again, that'll get into the second side of your question or second question. But if we're getting 50 or 60, so we accept roughly around 10%. So 10% of 3,000 will keep the numbers simple. We accept 300, we reject 2,700. If I'm only getting 50 to 75, requests for reconsideration, I think we must be doing a pretty good job.
Yeah, very.
Yeah. So the time, I know we're not going to talk about COVID very much, but the thing that's been most noticeable for me is that there must be a lot of people have time on their hands because the manuscripts are just pouring in, and so the numbers are up. And then I don't know whether this was a smart thing or not a smart thing, but I sort of threw out there, I said, look, if you want to send something to Annals of Surgery that's COVID related, we'll promise a rapid turnaround and immediate publication online. And so at last count, we were up to 400 submissions just on COVID-related topics in the last 6 weeks. And that has really increased the workload dramatically. And I give a lot of credit to the Annals production staff, because when I accept something and send it in the next morning, if I've done it at night, I will usually expect that it'll be available on the website and available through EPUB within 48 hours, which I think is remarkable. We've accepted, I guess, of 400 or so papers that we've submitted. I think we're pushing about 50 that we have put into press. So again, these are all available on the Annals of Surgery website, and we're now moving from papers that were all about the disease. It was a paper published in Annals which really set up the first question about the role of laparoscopy and I don't say this word very well, but aerosolizing viral particles, and whether it really happens or not is been debated. Whether the particles can be in smoke associated with cauteries has been raised, and so I think it was good to get that paper out right away. We've looked at a lot of papers. One of the ones we published was from the University of Pennsylvania on how to safely do a tracheostomy in these patients who, when you're cutting into their airway, you could get a blast of viral particles. So how to go about that? So the first few weeks were all about treating the disease and how to strategize and shut down your programs, do safe surgery, and safe decision making. And so those we've sort of run out of topics there. There's still a few that come through, but in general, most of what we're looking for now is how do we deal with the next phase? What are the steps for ramping up? How do we deal with education now? There's, I just got a memo. Harvard is not going to allow visiting students to come rotate at the MGH this year or any of our hospitals. How do we appeal to that group, which is oftentimes a strong opportunity for us to get to know the candidates who have an interest with us and have them audition with us, and for us a chance to impress them. So we're focusing our most of the papers that are being accepted now aren't about how we treated the COVID epidemic as we were on the peak of the crisis, but how are we going to manage it now that we've flattened out and we're moving into other areas. Although there is now an opportunity for people to report their actual results, and at first there was case reports of this or case report of that, or guidelines, or how I do it, or how we're doing this or that. I think there will start to be accumulating data on what happened to the transplant community. What are the true risks of transplantation in the COVID era? Should we be turning down organs and not bringing in patients who are well to get transplants? So I do think there are some results that are going to be reported beyond just we treated 12 patients who had COVID and this is how many died. I think there will be information that's gained and perhaps registries that are accumulated. But this step that I did, or misstep that I did, that opened the door up for 400 submissions on one topic in 6 weeks is changed my workload a bit, since I do most of the decision making myself. So I have done a lot of time. Chad referred to the fact that I do multitask pretty well, so I can generally assign and review a lot of decisions that have come from my outstanding associate editor group, and the recommendation comes from the editorial board and ad hoc reviewers that I can oftentimes multitask in doing that when there happens to be a sporting event on in the background or the like, or even a break between my biggest activity now is Zoom calls every hour or two, and if it's the wrong Zoom call, you can kind of check out a little bit and review decisions or do assignments while somebody's babbling on about whatever the topic is. You just sort of direct the camera away from your face so they don't see that you're looking at your computer screen.
Audio only.
So, audio only, yeah. So those were the second and third question. The first question was...
Yeah, I was just curious, sort of your overview of how you view that job, because I think certainly the majority of us in the rest of the world look at it as a really, really important and obviously prestigious job. I would say that you clearly, in so many ways, but in particular through the journal, direct the way that surgery is going.
So I do view it as important. I think that I have a lot of impact on 60 or so residents and 100 or so faculty, and maybe a an association here or there outside of our home base, but this is an opportunity to have a great impact on really the entire world and practice of surgery, and it's too big a job for one person, and that's why having a great associate editor team, a great group of people on the editorial board, a huge stable of people who are willing to put in the time, to volunteer the time to review manuscripts is so important, and so I think that it's sort of like service to our profession. If you're going to write papers, if you're going to read papers, I would hope people would always be willing to review a paper. Now, of course, if you're an acute care surgeon or a critical care surgeon this time of year, or not this time of year, but this crisis going on, I try to avoid sending papers to people who I know are up to their eyebrows with COVID patient care. But there's a lot of us who have not been on the front lines of treating patients who have really stepped up during this period of time, and reviews are coming faster. I've even had people who said that they've been quarantined because they had an exposure, and they said, send me some extra manuscripts to review. So I never turned down that opportunity. So,
Dr. Lillemoe, one of the things I've been most impressed about with the Annals of Surgery is just how on the forefront you have been with sort of pushing what the journal does. I mean, I think in an era where journals sometimes struggle to find relevance, I think Annals has actually been leading the way in terms of embracing new technologies. So, for example, I think the visual abstracts has been largely, something that Annals has really pushed. And then lately, particularly with COVID, Annals has been instrumental in really collating things on social media. Can you talk a little bit about how you sort of navigated that very tricky water of embracing these new technologies and keeping something like Annals not only relevant but really pushing, I think, the frontiers of how journals can interact with their readers?
So when you're sort of as tech savvy as I am and non-social media savvy, and to know that most of the people do agree with you that Annals has sort of set the stage for social media for surgical journals, I have to give all the credit to this string of great young, bright individuals, starting with Andrew Ibrahim, who was our first creative director and who actually sort of came up with the idea of the visual abstract. We've had a great series. Our most recent person, Karan Shaba, was very social media focused, even as a medical student. I remember we tried to recruit him as a intern applicant. He went to the dark side. He matched it to Brigham, but now he's working more closely with me because he's been our creative director for the last 2 years, and he's done a great job of taking it to the next level. The whole thing with the COVID site was really his idea. So again, surrounding yourself with bright, creative minds can make anybody look good.
Well, I do definitely think that it takes some bravery to take a journal that's well respected like Annals and put it into some uncharted waters. So I definitely think you deserve some kudos for that. What I wanted to also ask you if you had some advice for authors who wanted to perhaps publish their manuscript in the Annals one day after having read so many different manuscripts. What are the absolute do's and don'ts for any prospective author?
Well, first of all, it comes down to the subject matter. You got to find something that's new and innovative and interesting. And I think the days of my this is my series of the largest number of this or that getting published is not happening as much as it used to. Or at least not happening quite as much in the top flight journals. Although Annals probably still publishes a fair amount of those. I think you've got to tell a story that says more than just I've done a lot of these and this is what my results are. You've got to try to find what's important out of your results and translate that into a message which, again, advances the care of patients. So that's number one. Number two, construct a manuscript well. You need an interesting introduction. You need a well-defined methodology. You present your results in a combination of words and figures and tables so that they're very clear. You don't try to do too much, but still give as much information that's important to tell the story. And then finally, wrap it all up with a strong discussion of the relevance, including the whatever might be viewed as limitations of your study, and use proper have it if it's one of the best things about for me was with my South Dakota education background. My best friend was a Princeton grad, so every time I had a manuscript that I would write, Charlie Yo would we're generally co-authors. Charlie would always correct my English and make sure my sentences were constructed properly, whereas Dr. Cameron would just focus, on what's the key points of the paper, and so you best way to write a paper is to do it collectively with getting the opinions of multiple co-authors and make sure that things are said in a fashion that may seem perfectly clear to me because I know the data and I've written the data, but someone who doesn't know it quite as well will say, this doesn't make sense. You need to go back and rephrase this sentence or represent this data or look at this differently. So, the solo author manuscripts are just not going to work. So,
Dr. Lillemoe, we can't thank you enough for spending time with us again on Cold Steel. I just want to close with maybe two softball questions, and then again, thank you. The first is I think we all know that after your family and your professional career, maybe the third thing that comes into that is your love of sports. And certainly having seen your memorabilia collection and listened to your stories and some of the amazing events you've been to, I was just curious what your top one or two or three of those would be.
Well, again, blowing my cover here in Boston, I'm a Yankee and Raven fan, so I've got a lot of things that are Yankee related. One of couple of my favorite pieces are number one, when Andy Pettitte and Derek Jeter went out and took the ball away from Mariano Rivera on his last appearance at Yankee Stadium. I have that signed by all three of them. That's a favorite. Wow. I also have a picture of Ray Lewis, his last home game at the Ravens Stadium, where he does his little dance in front of the whole crowd, and signed by Ray and the team. So those are a couple that jump right out. Then I have a few that are somewhat important because I was at the event, like Cal Ripken, his 21-31 game when he broke the record of Lou Gehrig for consecutive games, and I have something signed from him from that day. And then I have some too from people I've taken care of. I maybe have to be a pretty deep sports fan to know there was just a Baltimore Oriole baseball player who had colon cancer in his 20s, 27, 28, just had colon cancer surgery, and some very hard-working beat writer for the Orioles published some stories about two previous Oriole greats who had colon cancer. One was John Boog Powell, and one was Eric Davis, and I just happened to be the surgeon on both of them. So, this was back in 1996, and to have those stories retold that related to this young man, and actually had my name actually brought up to the in the paper or in the article that the sports writer wrote. I've told this story again many times. There's this great line that your kids don't read your CV, but all my kids watched the day that I was the lead story on SportsCenter announcing, talking about Eric Davis's operation and his diagnosis, and it was sort of pre-HIPAA days, but actually holding a press conference live on SportsCenter kind of made it for me. So that sort of puts your statement, Chad, that sports is pretty important. So.
Wow, I love it. I'm just hoping you'll close us out with maybe providing us with a single or one or two of the most important pieces of advice you would have for both trainees in a surgical residency, maybe even a fellow, and then as a junior staff.
Well, I mean, again, I'm not sure that these are unique, but and I've sort of alluded to them, is get good mentors and watch how every surgeon acts in every situation, whether it's a tough case or an easy case, whether it's how they interact with nurses and students, and try to make yourself a composite of all the good qualities of people you see. And I think that doesn't matter whether you're a medical student, a resident, or a faculty member. You need to sort of take the best from everyone and also learn from what isn't good about people. And so make yourself a composite of the good things that surround you. And secondly, again, it's applicable to anyone at any stage. It was a line that the great John Tarpley still probably says is get in the habit of having good habits, which means, whether it's tying a stitch, you always, drive your finger down to secure the knot flat and do everything rather than get in the bad habit of doing it when it's maybe not as important, because if you don't have that tendency to have good habits, when it is important, you may make a mistake. So those are two generic things. Work hard, look for the right opportunities, always think ahead. I never have done anything thinking about what my next job was going to be, but you always want to position yourself so that whatever you do, you'll be there when the right opportunity will come along. So, I think had I not gone to Indiana and not done some of the things that we did at Indiana when the opportunity to come to the Mass General came along, I probably wouldn't have been a candidate. So never stop looking for new opportunities. Again, the Annals of Surgery story, I was asked by Dr. Sabiston to write a review article on pancreatic cancer. Who would ever turn David Sabiston down? So I wrote it and submitted it to him, and he probably just read it himself, wrote me back a nice handwritten letter, or at least hand-signed letter, long before the days of email, saying, thank you for such a nice review article, and oh, by the way, would you like to be on the Annals of Surgery editorial board? And had I just blown him off and said, no, I don't have time to write a review article, who knows what would happen. My whole life with respect to Annals of Surgery may never have played out. So, you can't do everything, and you need to know when to say no. But, as I look at the clock, it's 10:15 here on the East Coast, but I would never say no to you to do something like this, because I think it's important. And so you just have to be selective, but if you see a good opportunity, you should take it.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs canjsurge@gmail.com or connect with us on Twitter @canjsurge. Thanks again.